Well, hello, everybody. My name is Garrett Schmidt, and I'm the managing editor for bbcexhibithall.com. And I'd like to welcome you all to today's live webinar hosted by Roji Health Intelligence. And it is called 3 Ways ACOs Can Magnify Results with AI. Now, we originally had planned to do this a couple months back, and then it got rescheduled. So we're super excited to be rehashing it today. And actually, it worked out well because we had some new additions and some updates to add. And so these things are changing rapidly all the time. But real quick, a few items of note before we get started. This is a traditional webinar format, so everyone has been automatically muted and we can't see your camera or anything, so don't worry about that. However, we are going to have time for Q&A towards the end. So we would love to hear from you. So at any time during the presentation, if you have a question for either of our speakers, you can go ahead and drop it into your control module. There's actually a place for questions specifically. And so we're going to get to as many as we can during the allotted time. If we don't get to yours for whatever reason, if we run out of time or whatnot, someone will reach out to you afterwards with an answer. So even if we're wrapping up in the last second, go ahead and drop your question in there and we'll get to as many as we can. Finally, this session today is being recorded. So what's going to happen is about an hour or so after the conclusion, you're going to receive an email with a link to the recording as well as to where you can download the slides. And there'll be more information about how you can get in touch with the team and the speakers there. So without further ado, I would like to briefly introduce our speakers today. With us, we have Mr. David Halpert, and he is the Chief of Client Team with Roji. And also we have our CEO and co-founder, Terry Hush. Very excited to have you both with us today. So welcome.
Thank you, Garrett.
Thanks, Garrett. Okay, let's go. This is a big area, but we're going to bite it into a very small chunk about AI. And let me tell you in the beginning that I've tried to make this visually interesting to you so that you can use all of your different senses, as AI would, of course, in appreciating the content that we're going to deliver today. So a lot of the art is AI generated, some of it is NASA, and some of it are brain neurons. So you can guess which ones are AI or not, or actually I have credits on them to make it easy for you. So here's the opening thought. Every new technology has the potential to be fearsome. And that's because it has a huge impact. But we're here to present AI in an optimistic view towards value. Not that it won't have some unintended consequences or effects, but the important thing to recognize here is that no matter what technology you're dealing with, even way old technologies, there's the possibility that they create disruption. Well, they always create disruption in the environment, and so therefore they're scary. So let us begin. Let's start with your attitudes. Would you hire her to navigate your patient's care? So Garrett will be putting up a polling question shortly, and this allows me to see where you are going into the conversation. So your choices are A, yes, AI will provide essential staffing. No, it'll erode the connection with clinicians. And C, maybe you're just not sure. So let's take a minute for you to complete that.
Okay, looks like we've still got some answers rolling in here, so we'll give it another 10 seconds or so. And then we'll close it out, and then we're going to share the results as well so you can see where you stack among your colleagues. Okay, let's close it down in 5, 4, 3, 2, and 1. And I'm going to go ahead and share the results. Okay, Terry, are you able to see the results from your end?
No, I can't.
Okay,
Can
so
you?
we got 37% is yes, AI will provide essential staffing. No is 22%, and not sure is 41%.
Wow. Okay, a lot of people on the fence today. So let's see if we can clear some of that up. Okay, so what are we going to talk about today? Since I said we'd be breaking it up into chunks, we will provide kind of a macro view of where healthcare AI is, where it's going, where it might be deployed in value-based care, and what are the three target areas that we think ACOs can most benefit from in AI. This always comes up. Every time you want to deal with AI, you're dealing with the fear that it will replace human jobs, professions, dominance, that'll have effects on privacy and security of patient data. Everyone recognizes that AI is created by companies who are making money, and therefore there's a profit motive and other motives in play. And then, of course, we know that no technology is actually neutral. Even technology has biases built in. Even AI has built-in biases. And so these are things that we're going to deal with as we go through the issues. They affect not only your choices in adoption of AI, but patient choices, clinician choices in actually using AI. So what is it? Sometimes what's AI and what is human generated is very difficult to distinguish. So these are some very broad categories. On the machine side, you've got terms that are being thrown around in journalistic articles right now: machine learning, deep learning, neural networks, robots, algorithms created by computers, natural language processing, which is NLP for short, generative AI. It's a big range. You're using AI every day now, and you may not recognize it. If you're asking Alexa to fulfill your shopping list, you're using AI. If you're bringing up choices from Netflix, it's AI. It's not just basic analytics that are built into everything that we're interfacing right now. All of it is an interactive relationship with your choices. A lot of that is created with an AI layer on top of data and on top of your logins to various things. Now, what's human? When you create human algorithms that underlie programs and direct ideas, for example, risk assessment we'll be talking about today, when we create algorithms of risk assessment, we're deciding what creates a risk for the patient. If that was an artificial intelligence algorithm, it would not be decided by us. It would be decided by data and patterns that are identified in the data. So that's a very big distinction that you need to understand as we're going through what's created by humans, what is going to be AI. It's a layer on top of data. AI in healthcare really started strongly in the diagnostics arena. You see ophthalmology, dermatology, radiology being the big, strong beginners in AI capabilities for diagnosing tumors, diagnosing retinopathies, etc. And why is that the case? Because there's data that is consumable by the machine in order to get there. It's either image data or it's measurements of some sort, but it's rich. For the same reason, we see a lot of AI in drug discovery right now. It's putting together different components of the genes or what's wrong, and then developing the response to that in various molecules that could be included in medications. And so these are the areas, along with robotic surgery, that have not only a lot of data, but they also have really strong practitioner engagement, problem-solving practitioners who are looking for answers of how they can do better. And for that reason, AI is really targeted narrow tasks in the future, like the diagnostics. The future brings all of that together in generative medical AI. So here's an example that I pulled from Stanford's information that they're sending out about what they're doing on AI in the surgery suite. We're going to be seeing AI in the exam room, in the surgery suite, in the diagnostic capabilities, in the treatment room, and it will be iterative so that something will reach a stage in the therapeutic or in the stage of the surgery, and there will be a reaction, and the surgeon can simply ask out loud in regular human English or another language, what did we miss? And it will be responded to by AI doing all of its research, its instructions, and then the humans pick up the task again. It's kind of awesome. Healthcare AI is really pushing right now into the non-clinical areas. So you see a lot of emphasis on natural language processing, on the capability of reducing the burden of documentation for physicians, of having greater analytics available to clinicians. And then there's a lot of things going on in patient communications and marketing. A lot of that is more in the payer realm right now than it is in the provider realm, but it's coming. Just a couple recent articles about AI advancement. You've got it moving heavily into the EHRs right now. Epic in particular, just an article out today of collaborations that they're doing with various AI companies, way beyond nuance, but moving into generative AI. So what are the opportunities for improving value? And how can ACOs, and I'm picking on ACOs here because it's really a payment model that not only has risk associated with it, but it's the formal provider-led vehicle for dealing with improvements in medical advancement, affordability, patient care, equitability. And here are three that we're going to target today. Patient risk assessment, cost and control by improving clinical outcomes. So these two are together here, and then population health. And now I'm going to turn it over to Dave.
Thank you, Terry. I'm going to start by talking about patient risk assessment, and we will just dive right in because we want to have some time for questions at the end. So next slide, please. Patient population data is AI conducive, and so right now we're in a situation where all of the risk adjustment algorithms that are used in alternate payment models, whether they're ACOs or something else, they're retrospective. So ACO benchmarks, BPCI advanced target prices, etc. They look at the hierarchical condition categories and other events. In other words, what has already been diagnosed. And the distinction here is that AI can be predictive, can use patterns in the data to prospectively alert you to potential issues, and most importantly, illustrate connections between treatment profiles and the outcomes that they're producing so that there is the ability to learn as we go. Next slide, please. So, AI risk assessment, these are some of the pieces that we'll be covering, and these are going to illustrate how AI can facilitate more effective care navigation. And critically here, AI is going to help organizations to be able to see patients holistically, rather than seeing them as a set of visits or thinking about them as a patient with hypertension or a patient with diabetes. We're looking at the entirety of the patient. And as we're going to go along here, there are some issues that we need to address. So the first is that for AI assessments to be meaningful, the data driving these assessments must have the breadth and the depth to support complex decision making. And that is going to include types of data that aren't largely utilized, things like genetic data, for example. And there's also the next step to consider, as we move forward. So what happens when an assessment turns up an issue? Are there resources available for improving patients' health? And that's something that we have seen now. If a patient screens positive for depression, for example, is there a mental health practice in that patient's area that is accepting new patients? That's still going to be an issue with AI. So are there resources available for improving patients' health? And if so, are clinicians engaged enough with this program to lead patients towards these resources? Thank you. And Terry, I'll punt it back to you.
Okay, and now we're going to move into a second area, which is cost control and patient health improvement. And what I'd like to touch on first is the central tool, episodes of care, that really is the mechanism for looking at these two things in one big unit, because it combines the services and packages clinical outcomes and costs over a time delineated basis. We have episodes, we're using them to construct a view on both chronic disease and procedures and treatment variations. What they do is provide a real clarity on patient outcomes and cost variations. But here's the issue. They're really, really hard to construct. Even if they are clinically focused episodes of care, and I'm distinguishing that from bundled payment initiatives episodes of care, where the design is put a bunch of related procedures that kind of touch on the same thing together and then establish a unit price for it. An episode of care that is an analytic that wants to drill into cost and quality and outliers and issues really has to be focused on one kind of condition or one kind of procedure so that you can actually truly compare measurable outcomes. Now, AI, if AI were addressing episodes, it would be much faster. It could be with more comprehensive data. You could use different sources of data than simply provider data and claims. You could find hidden clinical areas for addressing costs and outcomes. And you could personalize all of the different patient interventions with understanding, perhaps using sources of patient preferences, for example, or provider capabilities. And you can target the areas with greatest priority when you're dealing with the solutions to the discoveries that come out of episodes. It would be very powerful if you had the data in order to do it. You can look at episode variations, patients in control and chronic decisions or conditions, sorry. It's not simply a variation that is limited to cost. You can look at and isolate patients with persistent poor control, because if you can use longitudinal data on patient values, you can really get much more into the actual patient trend and evaluate what's coming out of what that trend is. For example, if the patient has been in a persistent poor control in diabetes or hypertension for a long period of time and is not improving, and yet the patient is only on insulin and you've seen no change in the service data that you're collecting, is that an equity of care issue? Or is that an issue of patient adherence? It can raise the possibility that you can isolate that patient for population health screening or clinician review to evaluate the treatment of that patient, but only if you're collecting all of that information and have enough of a breadth for AI to function. It can change the treatment possibilities. If you're collecting different sources of data, finding different patterns in the treatment, people looking at me, the reason that the last date of this webinar was changed for my broken collarbone, would not look at me as a fit person and understand that I might fit into an algorithm of extreme risk based on orthopedic problems, accidents of some sort, all related to dogs. So finding people with dogs may be relevant, finding people who specialize in dog sports. The more information that can be gathered about how people are living, which is possible when you've got AI, not possible when you're looking at humans, the more you will be able to actually tailor the treatment possibilities and diagnostics to that particular patient. But here's the issue. If the physician who's transforming the value for how patients are cared for is not involved and is not in charge of a more of a broader team of clinicians and social and other individuals, an interdisciplinary team, none of that really matters because the physician doesn't have the power to use the AI information that's coming out in a way that can actually marshal the solutions for that patient. So we're really talking about where data and physician roles and patient understanding work together to provide ways of improving patient status. If we want precision medicine to be on the line of the future, then we've got to appreciate the physicians have new roles and they can't do it all, especially when you're involving more sources of data and more disciplines. So the issues that we have to address in this arena are how we're going to share data with physicians and other clinicians, the accuracy of the patient episode. It's really hard to get episodes right. The clinical integrity, making sure that the entry of other factors with multiple procedures and different surgical approaches or different events that occur at the same time as a particular condition-based episode or a procedure episode are taken into account without skewing the results of that. What is the pre-episode risk of the patient? What do we know about that? It needs to be adjusted in some way. And is there an underlying clinical pathway for every procedure? Do we know where we're going, for example, on the clinical arena so that we can actually evaluate the episode that occurs on the back end? And I'm turning it back to Dave.
Thank you, Terry. I'm going to go through population health and care navigation here. And on the next slide, we're going to talk about where we can find the biggest value for our AI buck. So as Terry described, it's going to be in that creation of populations and building episodes. So we're going to be looking at populations. We need to identify some of the key characteristics of each of those populations so that we can, so that the AI system can help you triage those interventions based on needs and resources. And when I say needs and resources, I'm not just referring to patients' needs and resources. I'm also referring to your organization's needs and resources. There's a well-documented staffing shortage abound, and it is very challenging to move the bar in the situation that we're in right now. And so whenever we're talking about how to deploy an intervention for an episode, it's critical that it is something that can be accomplished. It may look good on paper, but unless it can function correctly in the real world, in practice, it's not going to be effective. Next slide, please. So the first thing that a lot of people think of when they think about artificial intelligence are digital assistants here, your Alexa, your Siri, and several EHRs have integrated AI into their tool sets. By and large, ACOs have not been able to do that yet because they haven't had the opportunity. Several ACOs are built of practices with disparate data sources, and we all know how challenging it can be even to aggregate that data to link quality measures together to find the correct denominator for reporting to the alternate payment model performance pathway. So the idea of then integrating digital assistance from each EHR is well above and beyond a daunting task there. So what are the options for ACOs? Let's go to the next slide and we'll go into that. The opportunities for ACO in population health world when we're talking about being AI enabled, where are the opportunities? It is more than just adding a chatbot. AI can help you alleviate the overworked and burned out clinicians and staff by guiding patients through the system, and that can mean facilitating changes, or excuse me, facilitating screenings. It can mean identifying patients that are eligible for a certain type of intervention and care management, and also help your office in terms of building out your quote unquote front desk abilities to help patients again go through the system, but also just creating an opportunity for them to get appointments and create self-management programs with AI coaching. Next slide, please. This is where it gets a little bit more interesting. This is I think the single, and I have dogs, but this is still a very, very cute picture here. AI goes beyond digital assistants. There are robotic assistants in nursing homes that are available. So AI-driven pets can combat loneliness in nursing homes, and that is a key contributing factor to enhancing quality of life and preventing the onset of clinical depression. As we know, clinical depression is something that has effects in patients' chronic conditions and management. And when we're talking about being in a nursing home setting, it's something that can affect overall health as well. And so there are robotic assistants like this that can just bring a smile to your face just by looking at them. So having them there is a very interesting opportunity for ACOs.
And they make noises too.
Do they?
Oh yeah.
Oh, fantastic. Next slide, please. So there are also AI and robot opportunities for patients who are home-based. Robot assistants can help. On the left there, we've got Mabu, and robot assistants can help patients manage their chronic conditions, and that is especially critical when comorbid conditions that a patient may have amplify the complexity of that patient's treatment plan. So as you have more chronic, or as you have multiple chronic conditions and there are potential memory issues, it is very helpful to have something there that is able to help guide you through your treatment regimen. What that is going to do, it's going to prevent issues that come from forgetting medications, things of that nature that are going to wind up being extremely detrimental to the patient's health. But also, as we're talking about value-based care, those are clearly going to be very cost-heavy episodes that AI has the potential to help you avoid. The other one that we're looking at here, Myra, is like a virtual seeing eye dog that can help maintain patients at home, or maintain independence at home rather than transitioning to a nursing facility. Again, a very cost-heavy piece. And so if Myra is able to help you manage a lot of the fine motor, gross motor issues that are part of your activities for everyday living at home, then you can remain at home. Next slide, please. So there are obviously going to be issues to address here. And the first and foremost is, in what context will patients respond well to AI versus where AI's presence leads to frustration and disengagement? Actually, that's true on the provider side as well. So is the AI clinically relevant, or is it a showpiece? Oh, I'm sorry, I missed a slide back there. Sorry about that. Can we go back
It's okay.
one?
Do you want me to go back? Okay.
Yes, please. One thing we did not cover is end of life care. And AI, there are a lot of programs out there that look at end of life care currently. So, for example, in the enhancing oncology model, for example, one of the quality measures that is looked at is where should chemotherapy stop and where should hospice care start. There is a hospice care model that has been floated, and so AI also has the ability to help here as well. It can help guide decisions about the appropriate time to refer patients to hospice care, and then also provide clinical decision support to clinicians and staff to help manage that patient's hospice care treatments. Now I'm ready for the next slide.
Okay.
Thank you. All right. So issues to address. In what context are patients going to respond well versus leading to frustration? Is the AI clinically relevant, or is it a showpiece to say we have AI? There's no need to throw resources at something to say you have AI if there is no downstream effect. Is the data being used for AI predictions trustworthy? For example, as we're talking about building out episodes, are providers in the organization making specific diagnoses where we're looking at complications, other variations to those conditions, or are we just saying that, for example, the patient has type 2 diabetes? And then finally, will the deployment of an AI tool strengthen the bonds between patients and clinicians, or will they erode those bonds? All right. I'm going to move on now to patient communications. These two sort of flow directly together, and so I'm just going to keep on a roll here and move on to why this is not the first choice, or should not be the first choice for ACO AI adoption. First and foremost, what I said previously, it doesn't magnify the results. We want something that is not going to be a showpiece, and in this context for ACOs, it is a little bit. Provider-patient relationships can really suffer. If you are a patient and you are learning about a condition or a diagnosis or a treatment plan from someone who is not human, that has a very off-putting effect to it. There are going to be lots of questions that you have. And so being able to talk about them with a clinician there is no substitute for that. AI is not going to be the way to make that happen. Now, with that said, it doesn't mean that there are no opportunities here. There is potential using AI to eliminate some treatment biases. There has been a well-documented treatment bias or a well-documented bias for treatment patterns that are based on race, gender, ethnicity, and having AI in place there can actually offset that. Next slide, please. One of the things that people will point out when they say, well, ACOs or other organizations should use this for patient communications, they cite a study by JAMA. Alas, it's stuck behind a paywall, but where ChatGPT was deployed. And it was a study that was set up based on a set of evaluators looking at a series of questions posted to, can we go back, Terry?
I did.
Thank you. Posted to clinicians on a website called Reddit, where it was a subreddit called Ask Docs, where subscribers are able to pose questions to physicians. And the evaluators preferred the chat bots, and so that's where all of this buzz was generated. But there are some serious contextual issues that are missing from this study. First, the providers are obviously going to have liability issues to consider. They are not going to want to make a definitive statement based on information or a question from the patient until all possible information has been considered, and that may include a physical exam. So obviously, if you get a direct answer right away, of course that's going to be something that you're happy to get, but that does not necessarily make good clinical sense. The other piece, and this is the most important piece, is that the evaluators aren't actually in this study the patients. They aren't considering how it will feel from the patient's perspective to learn about an issue, a risk factor, a diagnosis from a chatbot versus what it's going to be to learn about it from a clinician. Next slide, please. So the issues that we need to address on this front is that the communications can't be effective without real consideration about the provider-patient relationship. Also, what information are the patients going to provide? It's already well documented that patients will lie to providers in a face-to-face environment. So when a faceless bot is introduced, there are a couple of possible outcomes there. One, it's going to be, for some, it's going to be much easier to, if you've got something that is embarrassing or you may feel guilty about, it's very easy to omit that from a chatbot. On the other hand, there are going to be some that are going to have an easier time putting it out there to something without a face. It feels like there may be an absence of judgment when it goes out into the ether. So you've got a couple of different sides to that coin, and they're going to need to be balanced as you think about how you are going to use AI in your system here for patient communication. And then finally, how quickly can we get this off the ground?
Let me add one thing to this, Dave, because I presented a picture of a physician facing a maze in which the physician needed to have a lot of data. And what we're talking about here is patient-directed communications, not or patient-direct communications, not what might be prepared by AI in order to give to physicians or to use for physicians or in some other context. So it's what we have is who's the intermediary providing the information to the patient? Is it coming through a bot or is it coming from the provider? Big distinction.
Absolutely. All right, I will turn it back to you.
All right. So let's talk about obstacles because we've talked about opportunities in various AIs, and I'm going to get back to the central question, which is AI is part of the data universe. It requires a source of data storage. It requires data to consume. And most providers lack the aggregated database to feed AI. It may be why patient direct communications is kind of first on everybody's list because it's a staff saver, but it doesn't require a lot of data. So what are the data sources that you need for healthcare AI? Well, it's the typical ones, but then more. So claims data in broad detail, clinical data, and I'm talking about longitudinal data sources so that you can see over time how the patient has progressed. Not only are many providers not aggregating data, but they're actively resisting aggregation of physician EHR data. That is like shooting yourself in the foot if your plan is to go to AI eventually. It takes a long time to really have the kinks in data worked out. It's not, data just doesn't match up and work. It is often inaccurate. The coding behind it is often inaccurate, and it needs to sit there and be evaluated for a while before it can be used in anything that is anything like AI, let alone regular human clinical decisions. The lack of longitudinal data is a big one. Even if organizations are beginning to aggregate data, a lot of the measurements right now are one-time, one-year data, like quality data is one value a year. doesn't help in really identifying what's going on with that patient. And until we can appreciate that the patient is coming with some history, then it's very hard to do a lot with AI. There's a belief in data magic, that data just automatically, as I said, matches, it works, it tells you the true story. And what really needs to have is a focus on data quality instead. Most ACOs and health systems don't have an integrated patient-centric database. That's not the same as a single EHR. The distinguishing feature is that the value-based care technology that is needed to really focus on data has a lot more pieces to it than simply the clinical record or the financial record or the population health record, which are often operating independently or one piece of that is missing. Few organizations even have a value-based care technology. They may have an analytics, they may have some of the pieces of it, but the patient can appear differently depending on which system they're in. So how do we proceed? Well, a lot of preparation. You have to build the data substrate. That's where it starts. If there's no data, there's no AI, and there's really no progress forward with value also. You need the analytics, you need to create episodes of care and have the basic tools in place in order to provide the mechanism for AI to function and to expand or replace some of the analytics and episodes functions that you have. You need to make sure that you have the technology that will measure your value-based initiatives. What is working, what is not working? Some of those can be done with AI, but if you haven't done them even through a basic analytic questioning or evaluative process, it's really hard to just slap AI onto that. Prioritize the AI efforts based on your goals is an important function. What are your plans for for improving your value? Are you predominantly a specialty organization in which your focus on value is going to be in specialty care models, and therefore that's where you really want to start your initiatives with making sure that your data is comprehensive and includes genomic data? Ensure that your patients are brought along so that they don't become obstacles in the AI process that you have. And these are our opinions here. The same as don't start with a chat GPT patient direct communications. If your focus is on value, then there's only really two big questions in choosing an AI solution. Does it improve the patient health status or the quality of the care? And does it enable clinicians to work more at the top of their license? Because if your clinicians can't work at the top of their license, then you won't be getting the value out of sophisticated data-driven tools. The physicians are too busy doing busy work. Just a little caution. I made one of the things that happens with any generative AI tool, especially in writing or art, is you create a statement. The statement responds. Portrait of a doctor on a precipice, reaching for people who are helping him to safety. And I don't know about you, but I think he's a casualty here. He's looks pretty beat up, and he does not look saved here by anybody. All AI and technology, as I said in the beginning, has unintended effects. And you have to be careful of those by making sure that the data that you're using and the tools that you're using are iterative and complete. And you're checking the accuracy of that. It can't operate on its own without a human at this point, even though we know that there is reasoning AI out there. And I think we can move to questions.
Okay. Well, this is very interesting, and I'm sure all of you out there, your heads are spinning around like mine, trying to take all of this in. There's a lot here, of course, and AI. We're just on the precipice of of a new world. So we do have some audience questions that came in. We're going to get to as many as we can. If you have a question that you would like to ask either of our speakers, go ahead and submit that now using your control module, and we're going to get to as many as we can. If we don't get to yours, someone will reach out via email afterwards. Okay, so well, let's hop in here in no particular order. First question is this: can AI help reduce burnout, or worse, cause a mass exodus of health professionals and doctors?
I'm going to answer that. Absolutely. I mean, there are AI tools that are designed to do that right now, and I think that's why the EHRs are moving quickly to adopt tools within the EHR to lessen the burden of documentation on physicians, make it easier to diagnose patients. Really interesting article that I mentioned earlier with Epic collaboration, where the AI will go out and search similar symptoms to a patient where the diagnosis was in question, and the AI will generate a bunch of options for the physician to investigate. Just a kind of a nice time-saving tool. The ability not to have to write in progress notes and simply dictate it and have AI record it in the record. That should help significantly. But the big thing that needs to be planned is a transformation of the physician's role so they're not doing everything and they're not responsible for every piece of communication and every piece of direction that has to come in working with patients. It needs to be a transformation that is going throughout medicine, creating the team and not just the one person.
Great question. Okay, next question here is, what about the risk of AI hallucinations, quote unquote, from a lack of complete data?
I wonder if that means that AI is the AI is going to hallucinate and make up stuff. Um, I suppose that's possible to do.
I
I
think
mean, I
what
think that picture of that physician and being saved was somewhat of a really bad hallucination,
I
maybe
think what
caused by not enough good data.
I think what they're referring to, and I actually I heard a topic on this at a recent conference I was at, is when you have a incomplete data set that AI is pulling from, because data or AI is just an aggregator, right? It is
Right,
a kind of a supercharged turbo pattern recognizer is
right.
kind of how to think of it. But if the data set that it's pulling from is incomplete, is that something that can or would cause big problems in the output, right? Garbage in, garbage out type of
Well,
scenario.
absolutely. I wouldn't call that a huge, and I would also disagree with your comment that it's just a data engine because certain AI does have human reasoning comparability at this point. And so we're looking at the rising cognition of AI being very different than simply pattern recognition. That's machine learning, and that is probably the earlier stage AI. But what we're seeing now is a lot more decision making. But yes, if the data is not there to provide the matter for AI, who knows what can come up?
Yeah, great. Okay. Next question here is, what roles, if any, will be replaced or augmented first by AI?
Uh, well, there's a lot.
I guess in the priority order, like what would we be expecting to see kind of in an initial sense being most affected? I guess, are we talking about clinical mid-levels? Are we talking about analytic? Um,
I think we're starting everywhere on the on the list, and I don't think it will necessarily be systematic. We're going to be replacing people who write, people who come up with stuff, people who do population health, technology that creates algorithms by people. Uh, AI is already being used liberally in coding. So we'll see either rapid advancement of technology because it's easier to code, or less people, or both, involved in coding. We'll see less personal assistance and more AI assistance, even as you saw the pictures of people being cared for at home by robots, less home health people, less nurses, less everything. So it's going to be, so the big question is, will there be less physicians? Well, there already are less physicians and not enough physicians to serve the population at this point. So I don't have a good answer on the physician or clinician front, but it's going to affect the workforce everywhere.
a follow-on to that would be, are there any human components that simply cannot be replaced over time, no matter how fast, how far in the future that we go by AI capabilities? Is there any jobs, positions, roles, skill sets that simply need a human touch?
I think people want to argue that strategic skills, creative skills, the ideas cannot be replicated by AI. I don't know whether that's true or not, or whether that will be true in the future. Certainly, the holistic view of of planning and execution. I mean, if there are networks of drones, I want to recommend a book before I go forward. It's called The Coming Wave, and it's by Mustafa Suleiman. And it's a fascinating book on AI and goes through all of the industries, including healthcare. Highly recommended. Coming out of reading that book, I no longer know where the limits are with AI. Um, but I do think that that's going to all be worked out. I mean, AI is going to be heavily invested in the military, in surveillance, in healthcare. I mean, we're talking about the good stuff today, but every AI that we develop for healthcare has applications that are in the military or in politics. So we just need to plan it and control it while we can. Control the direction, that is. I don't think we'll be able to control the existence of the technology.
Oh no, I think that already has a foothold. More than a lot of people would be comfortable with knowing
Mhm.
is already taking place.
Right,
And to your point, in not just in
mm,
healthcare, but in a lot of different industries. Um,
right.
we have time for one more question here, and this one actually also has a statement with it. And this is going back to the accuracy of data. She says, agreed that the accuracy of data is critical. And time again, we find that the data set, that the accuracy of data input is incorrect. And in turn, the data output is invalid. Have the AI
Right.
tools considered process analytics customized to a particular provider patient relationship? And she goes on to say, we think back to CAC programs that were data-driven and faded quickly from the healthcare arena after an initial push in the industry?
Well, I think that there's going to be a big push on the accuracy of data. It's certainly not there yet. I'd certainly agree with the questioner that there's a risk in bringing out all these things early before the data is well understood. And it's why AI is succeeding so well in the areas where there isn't a lot of contention about data. But as soon as you get into human input data, and that includes human decision making in the data, so coding. I'll never forget our very first years as a data analytics company. We were writing letters to patients on behalf of practices, and we discovered an error because the physician did not want to code. He wanted to code asthma instead of another diagnosis. And so when we were sending letters to people with chronic disease, and they were surprised to find out that they had diabetes and asthma and all these things, it was, oh my gosh, that's out there. It's the level of accuracy of the data is not very good right now. And it all needs to be vetted by AI, actually. I think AI could do a great job of identifying faults in the data by comparative techniques.
Okay. Well, we have unfortunately we are out of time, but I had one last question that I could get a one-word answer from you guys, and it has to do with what we were just talking about. And I think I know the answer, but here's the question/statement, and then we'll close out. I think I heard that it is preferred to have data aggregated from disparate sources in a single repository to run AI than it is to draw from disparate sources in real time to run the AI. Is this correct?
Oh, well, that speaks to more of a technical issue of what's the substrate in AI that you're using. Most AI is built on a substrate database in which everything is being combined. That's going to be less necessary in the future, as long as you can identify and solve the issues of patient information. So
Yeah.
I think the answer to that is it necessary? Maybe in the future it won't be necessary. The easier and probably safer way, given the current set of data, is to combine a lot of that data.
Okay. Well, clearly it's more than a one-word conversation. So who knows? Maybe we'll have a follow-on to this later on. But unfortunately, we are out of time today. I want to thank both of you, Dave and Terry, for joining us and for putting on this presentation. This is fantastic. If you would like to know a little bit more about Roji Health Intelligence, I would encourage you all to head over to VBC Exhibit Hall, and where you can visit their virtual exhibit booth. Terry, can you advance to that next slide for me? And there should be a picture of it on here. There you go. If you headed over to, again, bbcexhibithall.com, you'll see, you'll be able to visit their virtual booth. There's a lot of really cool resources. It's a really neat tool. You can read up on them, what they're doing in the space, and I think you'll be impressed with their service offerings. And if you want to get in touch with them, it'll be easy to do that. However, if you would like to reach out to them directly, we would encourage you also to do that. Terry, if you could go to the very last slide. There we go. Their information, both Terry's and Dave's, is here on the screen. So this will also be included in the slides that we make available for download. So you'll receive an email where you can reach out to them directly, or feel free to reach out to me as well. And I'm happy to facilitate an introduction for you. So I know there's a lot to chew on here. So if you have some questions that pop up later on in the day, and you're like, I want to, well, here's your chance. You can go ahead and send those questions to them as well. But thank you all so much for joining us today. Really appreciate your time. I hope you all have a wonderful rest of your week and a happy holiday season. So join us on the next one. Look forward to seeing you then.